Good afternoon, everyone. First, I'd like to thank the organizers for giving me the opportunity to present my work. So just let me introduce myself. So I'm Laure Rouch. I'm pharmacist in the Department of Geriatric Medicine at the University Hospital of Toulouse in France. So I apologize for my French accent. Today I will talk about antihypertensive drugs and their potential preventive effects on cognitive decline and dementia. This is my research thematic as part of my PhD. This presentation fits the category of research in progress. Actually, I will present the results of a systematic review that I've done as a first step of my PhD to provide to date an overview of the potential benefits of antihypertensive therapy on cognition. And to finish, I will just present the next step of my research in epidemiology. So, to begin, just a word of background and rationale. Vascular dementia had traditionally been considered secondary to vascular disease and distinguished from Alzheimer's disease, considered to be a purely neurodegenerative form of dementia. However, these two conditions often coexist, and there is strong evidence for a continuous spectrum of disease, suggesting an association between vascular risk factors and dementia, especially Alzheimer's disease. Chronic hypertension, particularly midlife high blood pressure, has been associated with an increased risk for cognitive decline, vascular dementia, and Alzheimer's disease. In this context, antihypertensive drugs might have a preventive effect, but the association remains poorly understood. Thus, the aim of this work was to examine all published findings, investigating the relationship between antihypertensive drug use and the incidence and progression of cognitive decline or dementia, and also to discuss the mechanisms that could explain these potential benefits. So, we conducted a systematic review according to the PRISMA statement to identify observational epidemiological studies, randomized controlled trials, and meta-analyses that investigated this relationship. We performed an electronic database search using Medline, Embase, and the Cochrane library. I will not give any more details here regarding the study eligibility criteria, but we can talk about later if you're interested. 38 publications corresponding to 18 longitudinal studies, 11 randomized controlled trials, and 9 meta-analyses were included in our systematic review. So, observational studies and antihypertensive therapy and cognitive decline. In the 7 longitudinal studies, assessing the effect of antihypertensive medication on cognitive impairment or cognitive decline, antihypertensive drugs appear to be beneficial. Here are some examples. In the Honolulu aging study, a lower risk of cognitive impairment was found with beta blockers. In the cardiovascular health study, 1,054 patients were included and were followed during 6 years, and a significant lower cognitive decline with centrally active angiotensin-converting enzyme inhibitors, ACEIs, consumption was also shown. And in the same way, a beneficial effect of ACEIs in reducing cognitive decline was also found in the real-FR studies among patients with mild to moderate Alzheimer's disease. Now, observational studies, but antihypertensive therapy and dementia. So, of 11 studies examining the relationship between antihypertensive therapy and incidence of dementia, only 3 failed to show a significant benefit, probably partly due to some methodological limitation we talk about this later. So 8 found antihypertensive drugs to have a protective effect. For example, also in the Honolulu aging study, antihypertensive treatments were likely to protect against dementia and Alzheimer's disease. And this analysis is particularly interesting because it considers the duration of treatment. You can see each additional year of treatment, so this is very interesting. In the same field, in the cohort from Veterans Administration, a decreased risk of dementia with antihypertensive drugs, even among patients without hypertension, was found, suggesting that they could be beneficial beyond their effect on hypertension. Intervention studies are more relevant in terms of analyzing causality. Several large randomized controlled trials have evaluated the effect of antihypertensive drugs on cognitive function and dementia, but with inconsistent results. For example, the HOPE study for Heart Outcomes Prevention Evaluation study showed a significant reduction in cognitive decline associated with stroke by 41% in the ACEI group. Besides, these results were found despite a modest reduction in blood pressure. In the PROGRESS study for parenteral protection against recurrent stroke, the ACEI-based blood pressure lowering regimen was associated with a significant reduction in cognitive decline by 19% in the whole population. However, there was no clear benefit regarding prevention of dementia except for patients who had recurrent stroke. The CISTURE study, CISTURE for systolic hypertension in Europe study, was the first to demonstrate a reduction by 55% over 4 years in the incidence of dementia, both Alzheimer's disease and vascular dementia, with a dihydropyridine named nitrendipine, a calcium channel blocker, possibly associated with an ACEI or a diuretic. These were the positive studies. Other randomized controlled trials, maybe you have already heard about them. For example, the SCOPE study for study on cognition and prognosis in the elderly, the IVET-COG study for hypertension in the very elderly trial, and so on, reported no statistically significant association, but perhaps for reasons that I will outline later. Finally, recent meta-analyses, including randomized controlled trials, have been performed. For example, in this study, where the IVET-COG, the PROGRESS, the CISTURE, and the SHEP trials were combined. And the pooled ratio was significant, corresponding to a 13 reduction in dementia risk. On the contrary, the Cochrane meta-analysis by McGuinness reported no significant reduction in incidence of dementia between treatment and placebo group. This lack of benefit may be explained by the exclusion of the PROGRESS study, remember, that was conducted on patients with previous stroke or transient ischemic attack, and the fact that in the SCOPE trial, for example, many subjects originally assigned to the placebo group received antihypertensive drugs, and we'll talk about this later too. Besides, the meta-analysis, not only this one, but the meta-analyses were often based on aggregate data, potentially less relevant than individual patient data. And to finish with meta-analysis, very recently, another meta-analysis disclosed very interesting results, a benefit of antihypertensive treatment on overall cognition and dementia, but with ARBs, angiotensin receptor blockers, being probably the most effective. And we will discuss this later with the mechanisms. Several methodological factors might explain the discrepancies between some of these studies, and sometimes the lack of marked benefit of antihypertensive treatments on cognitive decline and dementia. First, observational studies. They may have some limitation, particularly due to their design. The group of patients using antihypertensive drugs sometimes differed from those not using antihypertensive drugs, they differ with regard to a number of factors potentially related to dementia risk. And these limitations often lead to an underestimation of the association. Other potential limitations that I want to talk about may have contributed to an overestimation of the potential benefits of antihypertensive therapy. Self-report of antihypertensive drug use by subjects with subtle impairment of memory in the preclinical phase of dementia may have produced less reliable answers and consequently led to an underreporting of antihypertensive drug use in cases of dementia. Another point, indications for antihypertensive treatment may also have been associated with different vascular conditions, resulting in confusion bias. Misclassification of hypertension may have also happened because blood pressure often drops in the preclinical phase of Alzheimer's disease. And this might have led to discontinuation of antihypertensive treatment, resulting in a potential overestimation of the preventive effect. Attrition, it's very known, is also a common limitation, especially in cohort studies with elderly people. And finally, I want to discuss another point, which is very important, another limitation, which is survival bias. Users of antihypertensive drugs might have been more likely to die before non-users, particularly due to their comorbidities. They may therefore have escaped detection of cognitive impairment or dementia and may have contributed to an overestimation of the potential benefits of antihypertensive therapy. But on the other hand, users of antihypertensive drugs may have also had a longer survival due to better hypertension treatment, leading to increasing cases of dementia in the elderly, since age, is by far the stronger risk factor for dementia. Randomized controlled trials also have methodological limitations. In our systematic review, the lack of benefit may have been due to the fact that, for ethical reasons, numerous subjects whose blood pressure remained high crossed over from placebo to an active treatment group or were treated with more than one antihypertensive drug, leading to small blood pressure differences between groups and consequently reducing the power to detect, reducing the statistical power to detect a preventive effect. Moreover, due to their cost and complexity, randomized clinical trials are often designed with a relatively short duration of follow-up. Regarding the progression of cognitive impairment or the incidence of dementia, these randomized controlled trials may have been too short to detect a difference between treated and untreated groups, since antihypertensive drugs would have the greatest effect when they are administered many years earlier in midlife. Finally, these randomized controlled trials were not designed to assess the effect of antihypertensive drugs on cognition or dementia, being only secondary outcomes. Some of them, such as the CSTUR study or the IVATCOG study, were stopped prematurely because of benefits on the primary endpoint. So, overall, accumulating evidence suggests that antihypertensive drugs may be beneficial in preventing cognitive decline and dementia. So, what are the mechanisms involved? First, the potential benefits of antihypertensive therapy could be related to their blood pressure lowering properties. High blood pressure, particularly in midlife, is an important risk factor for late life cognitive decline and dementia. Long-term hypertension increases arterial stiffness, leading to severe cerebral atherosclerosis and promotes small vessel lipohyalinoses. These vascular changes may be at the origin of stroke, chronic hypoperfusion, and hypoxia, resulting in white matter damage. Actually, the ongoing hypothesis is that hypertension-related atherosclerotic and hemodynamic mechanisms would contribute to an early expression of a still subclinical Alzheimer's disease. By inducing vessel changes, high blood pressure may also damage the blood-brain barrier, increasing vascular permeability and protein extravasation in cerebral parenchyma. And this dysfunction would result in an amyloid accumulation. Thus, antihypertensive therapy may be helpful in reducing dementia risk via a blood pressure lowering effect. But some antihypertensive subclasses, we talk about this in the observational studies or in the randomized controlled trials, may also be beneficial for cognitive function beyond their ability to reduce blood pressure. Several studies, for example, have proposed that calcium channel blockers may possess neuroprotective properties. Indeed, calcium is involved in many specific functions in the brain, particularly learning and memory. Studies on rodents, for example, have reported age-related increases in L-type voltage-gated calcium channel, LVGCC activity, and calcium transport across the membrane of hippocampal neurons. This elevated intracellular calcium can cause apoptosis and increase neuronal vulnerability to neurodegeneration. Indeed, sustained levels of intracellular calcium may induce beta-secretase cleavage of APP, leading to the production of A-beta peptide. Calcium has also been shown to contribute to hyperphosphorylation of tau protein, underlying the formation of neurofibrillary tangles. And calpains, you know that calpains are calcium-dependent proteases, already known to have an increasing activity with aging, may be implicated, but we're not really sure. However, neurodegeneration is also thought to cause calcium dysregulation. A-beta deposition has been found to increase intracellular calcium in transgenic mouse models of AD. Lastly, mutations in tau protein, as commonly encountered in Alzheimer's, have also been shown to increase calcium influx into cells by altering the function of LVGCCs. Thus, calcium channel blockers that target LGVCCs and attenuate intracellular rises of calcium can exert some therapeutic benefit in the prevention of cognitive decline and dementia, especially Alzheimer's. Dihydropyridines that are able to cross the blood-brain barrier due to their lipophilic properties would be of considerable relevance. Several lines of evidence also suggested that ACEIs and ARBs, both renin-angiotensin system blockers, may especially have benefits on cognition. You know that renin acts on angiotensinogen to produce angiotensin 1, which in turn is cleaved by angiotensin converting enzyme to form the active form, to form the angiotensin 2. The latter, a potent vasoconstrictor, exerts its hypertensive effect following binding to its receptors, 81 and 82. And as previously described, hypertension negatively affects cognitive function. But angiotensin 2 mediated inhibition of acetylcholine release is also believed to impair cognition, especially for Alzheimer's disease. Conversely, although it has not been fully demonstrated, especially to some paradoxes between in vivo and in vitro studies, ACEI might be, so angiotensin converting enzyme, might be involved in degradation of A-beta peptide, which is a major component of senile plaques. So, under this model, it is clear that ACEIs, so inhibitors, could be beneficial on cognitive function by preventing the negative effects of angiotensin 2, but they may also reduce the positive benefits of A-beta degradation. Thus, angiotensin receptor blockers, while still allowing ACEI activity to go unaltered and potentially acting to positively reduce A-beta concentrations, might be more appropriate in preventing cognitive decline. To conclude, as I said earlier, you know that chronic hypertension, particularly midlife high blood pressure, has been associated with an increased risk for cognitive decline and dementia. Overall, the findings of our systematic review suggest that antihypertensive therapy may decrease the incidence and progression of cognitive decline and dementia, and not only vascular dementia, but also Alzheimer's disease. Several observational studies, randomized controlled trials and meta-analyses have found positive results regarding prevention of cognitive decline and dementia, but the results are sometimes conflicting, but this is probably due to methodological limitations, as we discussed earlier. Finally, accumulating evidence has suggested that antihypertensive drugs, particularly calcium channel blockers and renin-angiotensin system blockers, could reduce the risk for and progression of cognitive impairment and dementia, not only by lowering blood pressure, but also through a neuroprotective effect. Further studies are needed to confirm these findings, particularly in population at high risk of cognitive decline, with studies with longer periods of follow-up, and studies with cognition being the primary outcome. This would be of considerable importance, not only in terms of understanding the etiology of dementia, but also in promoting blood pressure lowering strategies in a public health dimension. So, just one or two slides to present the next step of my research in epidemiology. So, I'm starting to work on the VISA cohort, in French, Vieillissement, Santé, Travail, for aging, health and work. It is a 10-year prospective, multi-center French cohort. 3,237 subjects were included. We have data on cognitive function, memory and speed. We have data on blood pressure, on antihypertensive treatment, and a lot of covariates of potential interest. So the aim of my study is to compare the cognitive trajectories of individuals with and without hypertension, both prevalent and incident, and to study the potential effect modification by treatment status. Hypertension will be defined as either high blood pressure, so mean systolic blood pressure 140 or greater, or mean diastolic blood pressure 90 or greater, or current use of antihypertensive medication. And participants with hypertension will further be divided into controlled hypertension, so medication use and normal blood pressure, and controlled hypertension, so medication use and high blood pressure, untreated hypertension, no medication use and high blood pressure, and subject with no medication use and normal blood pressure will represent a control group. So statistical analysis will be performed using linear mixed models for repeated data. So actually I've just since last week some preliminary results, for now not ready to be presented, but indicating a faster cognitive decline among patients with hypertension. Among patients with hypertension, and effect seems to be more pronounced in those with untreated and uncontrolled hypertension, suggested the importance of blood pressure management for promoting healthy cognitive aging. So thank you for your attention. I also thank my collaborators and my PhD supervisors, Sandrine Andrieux and Philippe Sestac. Thank you very much.